will now be recorded.
All right. Hello and welcome, everyone. This is Caleb from TASC at the National Rural Health Resource Center. Today is Wednesday, April 29th, and this is the second meeting of our FY19 TASC Population Health Learning Collaborative. Today we have Rhonda Barkus from the center to talk to us a little bit about mental and behavioral health integration and how that relates to population health. Rhonda has a background in clinical psychology as well as a bunch of experience in rural hospitals and helping them with community engagement, amongst other things. I'll let Rhonda fill in some of those blanks that I left. But I, for one, am really excited to hear Rhonda talk about integration of mental and behavioral health and how that relates to population health. So similar to last week, we have about a half an hour of presentation, and then we'll open it up to discussion. Please utilize the chat feature there to the left. Up toward the top where you can mute your audio speakers and initialize or make your webcam functional. You can see the hand raising, agree, disagree options there. Feel free to use those if you have any questions as we go through. If there aren't any questions, I will let Rhonda take it away.
All right. Thank you so much, Caleb. Can you guys hear me okay?
I can hear you just fine.
Okay. Just wanted to check because it is getting ready to storm here, and I have a tin roof, so I hope that that's not going to be an issue at all. So I am so excited to be here with you guys today, and really honored to be invited to talk about mental and behavioral health and population health, because it really brings two pieces of my background together. Originally, back in the 80s, I was trained as a therapist. I was a licensed clinical therapist still. And I worked from like 1987 through almost 2001 in behavioral health and alcohol and drug treatment. Certainly saw a lot of changes in the world during those times. Back when I first started in alcohol and drug treatment, everything was always inpatient, 28 days for an alcoholic, 42 days for a drug addict, and there was never anything else. And so things have certainly changed an awful lot. So I have that as my background, and then as Caleb said, I work for the center and work with Tracy Morton. She's my director. We work in community and population health. So it's bringing the best of these two things, I think, together. So I'm going to talk a little bit about mental behavioral health and integrating care, and then also what it really means to move towards population health with this. And then I really hope that you all will have some discussion afterwards around what you're seeing in your states as far as what's going well. What are some of the best, I don't know, just the best hospitals or some of the challenges. But, you know, I think especially it's nice to hear from each other. What do you see people doing that's innovative and successful? Because that's always nice to give each other a lot of ideas on that. Right, so you guys know who we are, the center. I'm going to move right on. So I'm going to talk about, I'm going to revisit briefly a couple of slides that Tracy presented 2 weeks ago when she talked about using data to impact population health, just to make sure we're all on the same page and using the same words. Then I'm going to talk about integrating care and then the shift to population health, and then we'll have some discussion. You know, it's interesting because I was thinking about everything that's been going on in our world recently with the COVID virus, that this is almost what if we could design, or if we could really think about the move to population health, it would be exactly what's happening in our world right now, where there's a health issue. Hospitals are doing their parts, clinics are doing their parts, providers are doing their parts, but so are the frontline first responders, so are the school system, so is business, so are the nonprofits. I mean, so this is the ideal for, I think, population health, where everybody is involved to try to impact an issue. So I want to go ahead and start with this definition, because people always say, well, is it behavioral health? Is it mental health? What's the difference? Behavioral health is kind of the big umbrella word that's used to describe everything. So it's really the connection between our behaviors and our health and our well-being of body, mind, and spirit. Behavioral health then includes mental health. So again, it's the bigger umbrella, but it also includes substance abuse, and it's really considering a continuum of prevention, intervention, treatment, and support services. I do prefer the phrase behavioral health because it tends to hold a little bit less stigma than mental health or mental illness. So I tend to use that word more. So to go back to clarifying population health, this was one of Tracy's slides from 2 weeks ago. She talks about the need to think about population health as the targeted population or the bigger community health population. And so, for instance, I want to point out, like, when we're looking at impacting population health, I think it's really helpful to drill down to a targeted population, because it's a lot easier to impact the smaller population first, find out what works, and then we can look at the bigger community health. So for instance, a specific targeted population that we might decide to work on around behavioral health would be people who have diabetes and depression. So that might be a very specific group that we are going to create initiatives to address. And then this also was another slide from Tracy's, and I think some of the key words in this are care coordination, patient engagement, and those two words are really going to be tied to a lot of the slides that I'm going to talk about in just a moment. So why does behavioral health matter? Well, you can see a lot of statistics up here. 40 million U.S. adults have an anxiety disorder. 35% of the patients with chronic illnesses also have a mental illness. 28% of patient readmissions are due to mental illness. And so, you know, there's so many reasons why behavioral health matters here. And I think the other piece that makes this such an important topic is that out of all the areas that we are addressed by population health, whether it is COPD or diabetes, obesity, behavioral health is one of the issues that often crosses over all of those other chronic illnesses. So I think we just cannot ignore it. This is another visual physical diagnosis. 29% of adults with medical conditions also have mental health conditions. 68% of adults with mental health conditions also have medical conditions. So we can't really address one without the other. And then why it matters from a financial standpoint, the cost of chronic medical conditions when it's comorbid with mental illness, you can see the blue bar shows without mental illness the cost for treating cancer, CHF, diabetes, COPD, asthma, but then you can see the green line shows the how much higher it is when there is a mental illness. So I'm going to talk about two things then. Again, integrated care. And so I think the first part in really impacting population health is to be able to think about integrating care. And so integrating mental health, substance abuse, and primary care services produces the best outcomes and proves the most effective approach to caring for people with multiple health needs. So instead of treating everything in a silo, especially when we know that one impacts another, if I am addressing somebody's depression or diabetes, there's a good chance they might also have some depression. So if we are addressing things in a silo, we are not always being as effective as we really could. And so we want to be able to pull all of this together when possible and begin to move towards integrating care. As we think about integrating behavioral health with primary care, there are a couple pieces we have to think about. And here you can see organizationally what is going to need to happen in order to marry those two together, behavioral health and primary care. We've got to make sure that our leadership has the kind of culture that is able to do this. We have to think strategically. We have to collaborate and form partnerships to coordinate care, because coordination of care is the first piece in this. Develop staff capacity to deliver care differently. And so again, for somebody who has been a medical nurse or a medical tech, to ask them to start really also paying attention to and addressing things like depression or bipolar disorder, that's a big growing curve for a lot of people, or learning curve. We have to establish internal processes that make it easy for staff to be able to address both. And then we have to measure and monitor the data to see if we have outcomes. So that's the organizational perspective. The other perspective we have to think about, though, is operational. So operationally, what needs to happen? This is where we have to decide what specific population are we going to work with to bring together behavioral health and primary care. We have to find out what matters to the patient. You know, IHI talks about this being the most important question we can ask: what matters to you? We have to look at providing whole person care. We have to make sure that our care is coordinated so that there's a smooth transition for our patients. We have to look at social determinants of health that are going to support the person and their well-being. And then we're going to have to look at other social implications as well. So some of you might be familiar with the Minnesota Integrated Behavioral Health Project. That ended last year, 2019. I had the opportunity to work on that project from beginning to end. So this was several cohorts of hospitals, 4 to 6 hospitals in each cohort. And over the course of a year, they looked at addressing those organizational and those operational issues. And as I said, the project had ended last year. And certainly, as we all know, you know, some of our CAWs did amazing work and had amazing outcomes. Others struggled a bit more. You guys know that people are stretched pretty thin, wearing multiple hats, and so so often it depended on the person leading the project in the hospital and how passionately they cared about this topic. But those were some of the outcomes. There's a link up here to the Minnesota IBH project that's on our website, and I really encourage you to go on that website and take a look at how did we even create this project? How did we help the hospitals to look at what needed to happen in their hospital to integrate care? What were some of these measurable outcomes? What were the non-measurable outcomes? You'll see a lot of one-page spotlights on each of the hospitals. So it's just a wealth of information if you're even thinking about doing something similar in your state. And then here are some of the things that our hospitals actually did that resulted in those positive outcomes. One huge one, of course, was really making sure they had the right stakeholders at the table, and even getting some of their provider competitors at the table so everybody was working together, making sure that there was a resource directory so that the consumers knew what was available for services, because the idea was to get the consumer to use other services besides the ED for their care. Some of the hospitals created a universal release of information so that all of the providers had the same release of information so that they were able to share information with each other. Mobile crisis team to go out directly to the client's home and, again, to de-escalate situations and make sure that things were handled whenever possible so that the ED was not the place of care. There was a community navigator that helps to look at the client's treatment plan and are they taking their medication. A couple hospitals had a roving therapist that were available to go where they were needed, when they were needed, instead of people having to wait 3 or 5 days for an appointment. Client transport vehicle. One of the huge issues for some places is that there's not any transportation to even get to different kinds of appointments. And so a couple hospitals were working on doing that. And then another one that I'll talk about in a minute that was really big in Minnesota is implementing the Make It Okay campaign. So again, I encourage you to go on the website and take a look at some of the details around that. There are also a couple of videos that we have on there of some of the success stories. So this was the project around specifically integrating behavioral health, clinical care, working specifically with clinical care. That's only one part, though, of moving towards population health. The other part of moving towards population health is how do we really bring our partners in the community so that everybody is working on this together, and it's not just the hospital, so that we're really addressing just not our patients, but we're addressing our bigger community. So I think that this next piece of, actually it was part of the IBH project, almost as an afterthought, I think this was key to moving towards population health. Because if you think about it, in order to really address the bigger community, we have to be able to address stigma, because that's one of the main barriers. Over and over again, our hospitals in IBH were saying that the barrier that was the biggest barrier to helping them to move forward and to expand this to population health was stigma. And so a group of hospitals came together and decided they wanted to work on eliminating stigma of mental illness and substance abuse. It wasn't decreasing, it was actually eliminating, because that would make it so much easier for everybody to join in the conversation and to support. And so they created committees that included their community partners. It included school systems, the library system, other providers in their systems. Sometimes it included law enforcement. It included people in the community just had a passion for this. And so they created a group in the whole community that would really work on this together. So then it was no longer a clinical care issue, it became a bigger issue. And a couple things I want to point out here that I think were really, really important. So here's an example of some of the different partners that were pulled into this group to work on stigma. But a couple that I think are really important is up there, kind of the top left, about at 11 o'clock, is staff education to decrease stigma. Because one of the things the hospitals found is that to really move to population health, they had to start with their own staff in their own hospitals. Because oftentimes people were coming into the ED and then experiencing even more, just as much emotional distress by the way they were being treated in the ED, for instance. And so as part of the, eliminating stigma, I think almost all the hospitals really worked on doing a different kind of education with their staff and letting it begin there. It couldn't just happen in the community. It had to start with their own people. The other thing is down at about 4 o'clock, local businesses to help spread the message using art to change the narrative. That was another incredible partner. So a lot of the hospitals partnered with, if there was any kind of music, art, theater in their community, and they started partnering with them on how can we bring music, art, and theater to, again, help to eliminate stigma. And that group was able to reach people in a way probably nobody else could. You know, it's one thing to go to a health fair and talk about stigma and hand out pamphlets. It's another when you have concerts or you have artwork or you have theater presentations that impact stigma. So that was another really powerful piece. Here are some community event ideas. I mean, even if you ever Google things like musicians who focus in on this, or people in your community who do artwork around it, there's a lot of free material. There are a lot of plays out there that you could use. Lots of different community events, again, that were very engaging, that weren't just about handing out pamphlets. So some of the things that folks did, mental health first aid was huge in impacting stigma and moving towards population health, because it helped law enforcement, the schools, ministers, other professionals, other community members to understand a little bit better about behavioral health issues and how to address issues when they saw them. Hospitals started having Facebook pages that really helped to connect the folks who are coming to their Facebook with different opportunities with behavioral health. One hospital, their ED staff in particular, they had T-shirts they would wear every Friday that would bring awareness to the issue around behavioral health, and it would encourage staff in the hospital to say, hey, what is that on your shirt? What does that mean? And it would just create a conversation. Some hospitals did a press release just asking for community champions who would want to be a part of this. And again, you get a lot of people that are very committed that way, who maybe are recovering. They are dealing with mental illness. They have family members who have mental illness. So you get people who really care about this topic. Community presentations on Make It Okay, and again, there is a link for Make It Okay in the slide deck. This has been another big one to help reduce stigma. I know one community in particular, in their community, they have a yearly summer rodeo, and they have a parade in their little town, and so they had a float in the parade. So again, reaching people in some different non-traditional ways. And then having a youth champion group in the schools for that peer-to-peer support. So here are some different links to go to some of the campaigns that end stigma, whether it's SAMHSA or the Make It Okay. Some support for school-wide efforts to create a culture of mental well-being for students and staff, working through it, which gives you a lot of good free printable resources, research, and reports. It's amazing how much is out there. Also, I know that Caleb had provided you all with the link, several links for some resources around this topic. Some of the resources dealt with data. One resource I thought was really awesome was on the CDC. If you go on their website and you just start browsing around, they have a lot of tools and resources on if you decide to work, again, like with diabetes and depression. They give you a lot of guidance on how to really do that. So it's really nice to see what's out there from very credible resources so that we don't have to recreate the wheel. We don't have to think, okay, now what do? We just have to start talking and get the right people at the table, and it really begins to take on a life of its own. So I am going to pause there. That's what I wanted to share with you guys about, again, experience with integrated behavioral health, thinking about influencing stigma as a way to start pushing it out to the community, some ways to do that. So I'm going to pause and see if you guys have questions, and also to see what kinds of things you guys are experiencing in your own community.
Thank you, Rhonda. We got at least one question and one comment in the chat box. Was there a specific training or curriculum for hospital staff, or was it developed by each hospital?
That's a good question. It was actually developed by each hospital. They just did their own thing depending on what they were seeing. And I don't know. I haven't checked in to see if anybody's created that app, and that's out there. My guess is somebody has. we were to start Googling right now, we probably could find some of that. And especially if you can take something that's been created but then personalize it so it fits your organization or that person's organization, that's really nice.
And
Rhonda,
Stephanie had her...
Gary.
Go ahead, Gary.
Oh, I was just going to comment. I know there is training available. I'm not, but I would agree with what Rhonda has to say, that it should be customized for your rural hospital in that regard. But there's certainly information and training available to help deal with this.
Thank you. We had Stephanie had her hand raised. I wanted to make sure we gave her an opportunity to chat in her question, or *2 will unmute your line, everyone. Got a couple other questions coming in the chat box.
I think I've unmuted my line.
There you are. Howdy.
Hey, sorry, it took me. So when I want to mute, do I go back to *2?
Yes.
Okay, great. So Stephanie Nance, North Carolina, Office of Rural Health, and we are the State Office of Rural Health. So we actually have somebody on staff that is trained in mental health first aid, and that is really nice because what we can do is deploy that free to any community, and so we've done some mental health. Pardon me?
Sorry, I said wow. Go ahead.
Oh, so so that individual can go out to hospitals, and when he goes to a hospital, we will ask that hospital to engage their community partners. He's done training in some schools, libraries, safety net providers. So just wanted to put a plug for mental health first aid. It's really critical. It's a nice opportunity to bring lots of different folks from the community together to work together because everyone knows the individuals that need the help, and they've encountered them in different settings. And so for them to come together, it really creates camaraderie and a better working relationship to serve the patient. So I just wanted to put a plug. If you have somebody on your staff that can get that training, that makes it a lot easier, because then you can just go to the safety net provider and say, this is free for you guys. I mean, yes, it'd be really great if somebody could find some money to pay for lunch for the group. We've got some grant funding to pay for the books, but in times when we don't have the funding, I think the books are like $7 each. So it's not that expensive if you have to ask the site to help support it. And almost, we've never had trouble with space, because between the hospital and the local community collaborative members, somebody's got a room big enough. So thanks for letting me share.
Oh, gosh, thank you, Stephanie, for letting us know about that. That is such a great idea, because you're right. I know when we were doing the IBH project, several of the hospitals wanted to do mental health first aid, and it's like, oh, there's a cost for it. We don't really have that right now. Some of them did send folks to be a train-the-trainer, but I agree. If you can offer that to your hospitals, what a huge help for them. And like you said, there's nothing like bringing the community around the table together, learning all of the same information at the same time. That creates just a new kind of energy around this, and also a new, a new collaboration. Like even like when you've got the police and the ministers and all these folks together, it's like realizing that they're all in it together, and everybody has the right intention, just don't always know what to do. Thanks, Stephanie.
This is Stephanie, the other Stephanie in Idaho, and
oh yeah,
I wanted to piggyback. So we'll have like Stephanie squared on the mental health first aid, because I actually didn't know anything about it until last year, and we had done some competitive subgrant opportunities, and one of our critical access hospital nurse practitioners was, oh, I'm sorry, I'm echoing, I'm not sure why, but she had asked for funding for this, and then was able to expand it out to other her community and police and everything like that. And then our community paramedics. I have 2 local groups that asked for that this year. So we put it on hold because of COVID. Sorry about, and I'm going to stop talking, but that was also something that they had expressed interest in.
That's really cool.
Okay, thanks. Yeah, it's really good to hear that folks have that. So other questions or other things that you know is going on in your state, or that maybe innovative or different ways that your hospitals are addressing this that you're aware of. I'd love to hear your ideas. And again, it's *2 to unmute.
As we wait, excuse me, as we wait for some of those questions to come in, we'll just discuss some of the things in the chat box here. Jill mentioned that effort to decrease stigma around substance use and opioid use are very similar. So mental health stigma as well as substance use and abuse is very similar, reducing that stigma. So that's, and it's good to know, because I wouldn't necessarily have thought that just from an outsider, that I would think somehow substance use would be a little different, decreasing that stigma than mental and behavioral health issues. So that's good to know. Trish Rivera asked whether or not there are any hospitals connected with trauma-informed care in any way.
So with IBH, there were a couple that actually addressed that. For those of you all, if you're not familiar with what trauma-informed care is, it is as providers, hospitals, making sure that we are providing care in a way that does not continue to traumatize people. So for instance, if you have somebody who, you know, maybe providers don't necessarily know this, but you have somebody who is a, I don't know, an abuse survivor, for instance, and you put that person in a room, and somebody just kind of walks in and maybe approaches too quickly, or you have, they're gowned up and they're feeling very vulnerable, and then the person comes in and starts asking questions in a very non-supportive way, goes out. I mean, those kinds of things can actually continue to traumatize people, even just getting care by the way that we're treated, or if there's, if we just open the door and we don't knock first, and so we startle people. So really thinking differently about the physical environment where we're providing care, and then also how we carry ourselves in a way that is not going to continue to traumatize people. Because you guys know some people without a good bedside manner, you can walk away feeling a little traumatized all over again. Or if somebody does a procedure to you and they don't explain to you first what they're going to do. So yes, so some of the hospitals started really thinking about that. My hope is that more hospitals will be doing that, and I think it takes a really strong advocate in the hospital who even understands trauma-informed care, but then start educating the staff about it, and then having a leadership that's willing to think differently about that. So, and I don't know if any of you who are on the line are aware of anything going on in your hospitals, again, around trauma-informed care.
Sarah mentioned that adverse childhood events, ACE trainings, are a good resource for youth populations related to trauma-informed care.
Yep. And again, I think the more education that staff can have on things like ACE, it helps folks to be a bit more aware and sympathetic and cautious, because we don't always know what somebody's history is and what they've dealt with, and so we need to be able to be a bit more, I don't know, sensitive to those kinds of things. So yeah.
Yeah, oh, just being aware of it too. Like you're thinking of the examples that you gave when you're in a hospital room explaining that, hey, I'm the x-ray tech and I'm going down to take you for an x-ray. Are you expecting an x-ray? We're going to take a look at your ankle because of this or that. That's what it says here in your chart. Does that make sense? All right, let's go for a ride. As opposed to, Mary, let's go. It's a huge difference, and it really does have an impact on every patient, let alone one with underlying issues, for lack of a better word.
Mm-hmm.
So
if I start doing a procedure.
Yeah.
Sorry.
No, I think that, yeah, absolutely. So
yeah, if I start doing a procedure. Go ahead, Caleb, sorry.
Just bringing that into the consciousness and awareness of everyone within the hospital or the emergency room, the truck, or wherever that is, the grocery store, the workplace, whatever that is in your community is beneficial. Just as little as introducing yourself and telling why you're in their room,
mm-hmm.
their house, their appointment, their meeting space, whatever it is super helpful. And I think there's some power issue dynamics there too that are helpful.
Yeah, that's a really good point. And always asking permission before we do certain things.
We had a few more. I was just going to get to that. So Natalie said
okay, go ahead.
Stuff going on in Montana. She posted a link there related to behavioral health training for community health workers. They had a grant that allowed for reimbursement for the training, and it's been very popular. Can you unmute your line, Natalie, and tell us a little more about that?
Natalie's typing. Are you not on the line? Maybe text, Natalie. While she's typing, I'm just thinking, boy, doesn't that make sense. Community health workers would have that kind of training. Again, knowing the prevalence, this is not something that's really a rare thing.
I wonder how many...
When we're wanting to do no harm, when we're wanting to help people, we don't want to do something that just creates more harm because we don't know or we aren't educated about it or we're not aware.
I'm wondering if how many opportunities are found. So I'm thinking a community health worker going in the home after my discharge and then identifying an opportunity to help address behavioral mental health need. You know, if I come in with COPD exacerbation, I might get that treatment for that acute episode, but it might not address any of those chronic behavioral issues that I'm having that help contribute to that. But community health worker, patient navigator, someone like that who can help identify those things can be a huge benefit to me as a patient, but the community and everyone if he or she can help identify some of those things that an ER nurse or, you know, someone dealing with an acute issue might not see.
Mm-hmm. Yeah, and you know, and again, we know one thing impacts another. If I am taking medication for heart disease, or I've had a heart attack and I'm depressed, then I might be not very motivated to take my medication. So one absolutely impacts the other. And I see, so Natalie says she's not able to unmute, but she said she's going to share more of her via your Teams link about that information.
Yeah, that'll be great to have it in the Teams world. Andy said he can make sure that link that you posted in the chat box, Natalie, is available in the Teams world as well. So all that stuff will be there. But yeah, I think it'd be great to hear a little more about that project and just how it's going overall. I think it's really, really neat. And I know I've talked to Jack about it a little bit here and there, but I think it's really neat. So, Rhonda, I wrote down just kind of getting partners, specifically law enforcement, on board. And I was reminded of that when you were talking about your community partners and kind of coaching everyone up, getting them on board. And I remember it was a year or two ago when we had the supplemental project through the Flex grant. We were able to provide Flex programs with additional funding to focus on substance use or something else. And a number of Flex programs in hospitals focused on substance use and abuse efforts. So even just take-back programs, getting boxes available, but a number of them worked on projects within their community and their hospital related to reducing stigma, getting Narcan or other therapeutics out there in the world, so first responders had access to these drugs. But I remember hearing that there was pushback from some local law enforcement, like, that's not what we're here for. We're here to, to do whatever, but that is not what we're here for. So I was wondering if you had any thoughts or suggestions on how to initiate those conversations, how to help, or examples of how successful programs have addressed those. And I don't want to just pick on law enforcement. I know there are other entities who have pushed back or are hesitant to fully embrace no stigma or, therapeutic medications or whatever it is, a different scope of practice. Hospitals sometimes don't want to engage in population health because that's not what they're there for. Do you have thoughts on that?
I think a couple things is when you're thinking about approaching law enforcement, think about the best person to approach that group. So sometimes it's the community champion or who's really passionate about this topic. Sometimes it's not. Sometimes when somebody's almost too passionate, then they're going to be too hard-handed about it. So you really have to figure out who's going to be the person to approach law enforcement that will have the most credibility and the most influence, and then really figure out what is going to be the messaging. So if I go and sit and talk, I'm going to make sure that I'm able to express, this is the issue, this is what's in it for you and for me if we can work together on this. If we're working together, then your jail is being filled up with fewer people who are just having behavioral health issues. And so really letting folks know what's in it for both. I know one particular hospital in the IBH project that worked very closely with law enforcement, and specifically it was around helping to address folks in the local jails because people were in jail. They were having some behavioral health issues. Those issues were not getting treated, or they were treated while they were in jail, but then they would get out of jail. They would not have their medications, then they would start acting out again, and they were back in jail again. So I know that one hospital partnered specifically with the jail to make sure that there was really good care coordination while the person was in jail, so that they didn't have to they weren't continuing to be arrested for behavioral health issues. Does that make sense?
I think so. I think that makes a lot of sense. And Jill Osterly has her hand raised. Are you able to get unmuted, Jill? Star 2.
I am. Can you hear me?
We can. Howdy.
So Jill from Michigan. And along that same thought process is with SUD in that stigma, what we have found that works and has a great impact. We've done a number of grants through the RCOR and HRSA for the opioid epidemic, and we start each of our meetings and each of our activities with a person with lived experience, and just to share their story in terms of what they've gone through, but where they're at now in that recovery and that celebration of of being in recovery. And we have found that has had the largest and most impactful process. That it's just been amazing between providers, local community members, law enforcement, EMS. The largest impact really has come from the individuals in recovery sharing their story and helping them understand that it's very human, that it's not a moral failing, that it's part of everyday life for many, many people. So just thought I'd share that.
That is brilliant. That's brilliant because it gives it a human face, but the other thing it does is it creates an emotional reaction for the people who are there listening. And change usually has to have an emotional reaction. If I just keep talking at somebody and trying to make them see why they need to do something different or why they need to get on board with this, that's not going to have much of an impact. But boy, when somebody shares a story and you have that, oh my gosh, this is a real person and there's a face to it, then folks are so much more willing to engage. So that is brilliant. What a great idea.
Yeah, I like that a lot. It
This is Maria.
Go ahead.
This is Maria Bustamante from Texas, and here in the state we have it's called Tony, and they have an Narcan education, and they're an initiative that they started. It was started by two people who their own lives were saved by Narcan, and they are going out to communities. They're having some resistance. Sometimes you can even see the resistance in the participants' faces. It can show, but they're working with law enforcement. Even here in Austin, they gave a big donation of Narcan doses so that police enforcement can carry it with them and save some lives that way. It's not the whole solution, but it is part of it, I think.
I think that's really, yeah. Robert, you had your hand raised? Star 2 will unmute your line.
Right now, I think I'm unmuted.
Yes,
Yes,
this
is Robert from Texas, and I had a question in regards to the IBH group there in Minnesota. Did any of them look at any funding streams to sustain some of these behavioral health programs? Because, for example, I know here in Texas, some hospitals do have what they call like a senior wellness center for the senior renewal center for some of the Medicare patients. But of course, with that, when living in rural, there's transportation issues, so they're only able to pick up certain patients depending upon what appointment they're going to. So I was just wondering if there was any outcomes from the group around funding and making some of these behavioral health services sustainable.
Well, so a couple of thoughts. Some were supported already by the hospital, and they were able to do that. So, of course, none of this was like creating psychiatric units or anything like that. It was really about more just making sure we had the right operational processes in place with our partners to support folks with behavioral health issues before it becomes a crisis. So that was it. They were trying to move away from too much crisis management. I will say that the hospital that bought the vehicle, the police had donated that, and then I'm trying to remember who it was. Tracy, I know you're on, so if you remember, please jump in. They were partnering. They did partner with somebody in their community who was willing to split the cost of the insurance for the vehicle, like moving forward. They had volunteers who were trained to actually drive the vehicles. So beyond that, I don't know. Those are the only ones that I'm aware of.
Let me jump in on this. This is Terry, because I've been wanting to add this piece, is that In the value-based model, so going back to a previous one of our VKGs, we now have identified, if you talk to the accountable care organizations, PATSC in Illinois, the Caravan Health, as we're moving into Medicaid, North Carolina is going into a Medicaid ACO, on and on. What you find is when you start looking at total cost, behavioral health jumps out at you. It means, for example, that a diabetes patient, we've got data to show that a diabetes patient that has depression might cost 3 times as much as a diabetes patient that doesn't. And when Caravan Health, which has is the largest ACO in the country, just in terms of sheer members, when they identified what is our top issue here, mental health came to the top. And so what I'm saying here is if it's not available locally, if you've got hospitals or clinics that are part of an accountable care organization, it really pays for them to invest in integrated behavioral health or to come up with other strategies to kind of solve these issues. And I was going to suggest, for example, those organizations like I know Michigan and Illinois are working with their Blue Cross Blue Shield organizations, meaning that Blue Cross Blue Shield should want, there are now sources of funding coming out from the payer side of it. On the Medicaid side of it, same sort of thing. We know how much this is costing us in terms of our Medicaid dollars, Medicare dollars, we know that as well. So I'm going to suggest that another way to approach this is that if you've got a hospital in an accountable care organization, or if you're considering global budget, I know Idaho has been looking at that, Pennsylvania is already in it, these interventions in mental health and behavioral health become solutions to these particular models. So I think that's one thing. The other thing I want to throw in before the end here is we now have new ability to do telepsych and telemental health too, coming out of our rural health clinics. So the CARE Act opened up funding the possibilities of actually doing some of this mental health actually coming out of our hospitals and clinics. And yeah, maybe we don't have a psychiatrist there, but at very minimum, we could have some mental health or some social workers that might help with this as well.
That's a good reminder, Terry, and all the therapists that I still work with and that I know, they're not in the office anymore. Everybody's doing telehealth.
And a plug for telehealth, our virtual knowledge group webinar will be Monday the 4th at 2 p.m. focused on telehealth. We have an infectious disease doc who's working on telehealth project kind of nationwide, mainly in Arizona and Colorado right now. So we'll have some COVID stuff. We have one of the, it's not the Office for Advancement of Telehealth, it's kind of one of the subsidiaries who will be there to reference some of the resources. So that's Monday the 4th at 2 p.m.
Caleb, I want to go back and answer Natalie's question if I could.
That's exactly where I was going. And then I wanted to see about just reviewing the homework assignments. We got about 6 minutes left. So I think Natalie's question is really beneficial and important for the group. So I want to copy that so we can paste it into the Teams world. But for those who are still here or on live, let's talk about that a little bit.
Yeah, so she says, I'm curious for any other tips for engaging hospitals and their community partners around mental health, behavioral health. I find many of the hospitals we are working with are so resource limited that mental health, behavioral health is such a large nebulous topic that they're almost afraid to take something on. I think that is absolutely true because it feels impossible. It feels most of the communities don't have enough resources. And it feels so huge that very discouraging. So I think if you can get the hospital to really just drill down on one very small area. So for instance, what is an issue that they are really working on? Is it they are really addressing the senior citizens in their community, okay? Well, is there the opportunity to work with depression and senior citizens? Or if they are really addressing pregnant moms, okay, is there the ability to look at behavioral health with pregnant moms? So find out maybe what's important to them, and then see if you can tie into that and really keep pushing folks to stay focused on one little population first. Because I think I've actually even heard people say, oh, I feel guilty because I'm not addressing everybody. Well, we can address everybody. Let's start somewhere. And once they can see a little bit of progress in one area, then it creates more confidence to move forward. So that would be my suggestion.
Yeah, and I think Jill's point that it takes a champion within the hospital that has that passion. You need someone there. You need an advocate. If it's the CEO is passionate about behavioral and mental health, great. If the CNO is or someone, you need an advocate. You need someone to unlock that door from the inside for you. I think the types of resources are also super helpful. So to Natalie's previous comment of we're training people or able to train people within your community, not asking for you to continue doing that. Like we can give you the skills and ability to continue this moving forward. That is huge. When I was a flex coordinator, we were trying to get diabetic self-management coaches trained in communities, and some of them were all about it and could see that, and some of the CEOs were really, really difficult to get to that point. But if you say, look, I'm not trying to have you hold meetings or send your people to add this cost, but if we can train Jill to have a meeting and you employ Jill, then you're going to get all these people. So they're seeing how that is helpful as well. I see Jill posted another resource in there for us. Thank you, Jill. And we'll make sure this, these resources, all of the links that have been posted in the chat feature or in the chat box, we'll make sure those get into the Teams world for everyone, so you're able to go in there at your leisure and reference the resources that everyone shared, and thank you for sharing those. I also posted that question in the post in the discussion forum under the mental and behavioral health section in Teams, as well as that quick little suggestion that I was able to capture as Rhonda spoke about just getting one win. Like let's focus on one small area and kind of build from there. But we can continue that conversation within the Teams world. Any other questions? As Rhonda put up the behavioral or mental health awareness month. May is mental health awareness. That's pretty soon.
Yep, it's a good time to reach out to your hospitals.
Yeah. How did everyone find the homework assignment? I know we had a couple questions about, hey, I'm not exactly sure how to do this, and I think that was, I think that part of that's okay, because it is difficult to find out how many behavioral mental health beds, inpatient beds you have in a state. Like I said, I did this job or that job as a flex coordinator for a while, and I couldn't tell you anywhere. I have no idea how many beds there are in Colorado or in Minnesota where I live now. How else did you guys find the homework? Was it helpful? Was it helpful in thinking about things that your flex program can possibly do moving forward, or do we have more questions while we have Rhonda here on the line for us, guys?
And I will respond, Caleb, because I know there were questions around like the psychiatric beds, and so that was really fascinating to me because as I created the homework, I didn't necessarily tie it to the links. I was just thinking about what's helpful to know, and I thought it's helpful for folks to know how many beds do we have in our state, and it was amazing how hard it was to find. Right, so. Like I live in Georgia, and the site I actually there were several. The Treatment Advocacy Center, I found a link as I was looking for that myself, and saw that they actually recommend 50 psychiatric beds per 100,000 people in the state. The state of Georgia has, as of 2016, had 954 beds, which is only 9.3 beds. So 9 beds when they're actually recommending 50. So it was just kind of eye-opening to me, number one, how hard it is to actually find information. The other thing is I hope it got you to start thinking about, what are some of my cause, what are some of their needs, or what's going on in different areas. So for instance, do I have a cause that's in a group, in a place where there are a lot of veterans living? Okay, well, do we have resources for veterans? So just maybe more questions than answers.
So it looks like it was difficult to find the amount of psych beds, which I'm not sure we're too surprised by that. It's tough.
Yep.
So Trish just Googled some of the questions for Texas and found some data, and found, unfortunately, that the state has grown and the beds have decreased. And Kathy also found that to be the case.
Yeah, I did too.
So as you guys continue to think about your action plans following the Learning Collaborative, so these are examples of things that we think would be helpful or beneficial or possible projects or efforts that a FLEX program can or could conceivably do out of their FLEX program. Maybe not each individual, but contract with or something like that. So as you guys are going and you're thinking about that, if you do have further questions or additional questions about any one of the topics, please let us know. That's another benefit of having the subject matter experts that we do on staff at the center. Rhonda's pretty accessible. She was on a meeting with me just before this, and we are both a couple of the early people at the office, so I can always ask her some questions and get some support and answers. And we did ask all of the participants to be available for additional questions. So as we go, if you guys do have additional questions, please don't hesitate to let us know. All of the resources, questions, links today, everything's available there in the file share, but all of this stuff, will be available in the Teams world for download, for discussion, to continue this discussion. So if you have additional questions, please don't hesitate to put them in there in the Teams world. Send us an email and let us know